Hello, I'm Ashley Quintanilla and I'm going to be performing my head to toe assessment. Today I'm going to be showing you the supplies I'm going to be using. I have my reflex hammer, my otoscope, a pen, my tuning fork, my three items I'm going to be using for the smell. I got a Q-tip swab, a gauze, a tongue depressor, and this is my patient, Andrea Barrera. She is my youngest sister, and she is giving me verbal consent to do the assessment on her.
Yeah.
Okay, I'm going to first start off with the head and neck assessment. First I'm visualizing the head and the scalp, that it's even. There's no deformities or abnormalities. Feeling the scalp for any lesions or nodules that may be present. The texture of the hair is soft, thick, no balding noted. I'm going to go ahead and view the eyebrows. I view that they are even, bilaterally symmetrical. Her eyelashes too are evenly distributed throughout. I'm going to have you close your eyes. I can view if there was any crustacean or from the lacrimal duct, any drainage. Go ahead and open your eyes for me. I'm going to go down and look at the conjunctiva. It's nice and pink. If it were white, we would be worried for a pale, for anemia. That would be a sign. Also the gums, when I do the mouth assessment, that's another indicator if they're pale. Going down to the nose, it is midline. I see no deviations of the nose. Coming down to the mouth, the lips, I see no lesions around the mouth, no cracks. Everything is midline. Coming down to her neck, I view the trachea is midline, no deviation. I see that the patient does have some acrimosis around the neck area. Ears are equal and bilaterally. Next, I'm going to start with the lymph nodes on the patient. I'm going to go ahead and start off with the preocular, right in front of the ear. Just going to circular motion, noting for any tenderness. Then I'm going to go to the post-ocular, behind the ear, also feeling for any hard nodules or lymph nodes. To the occipital, this is behind the neck area. Post-cervical, right here behind the head. The cervical chain as I come down. Tonsillar, right around here. Submandibular, right in between the jaw. Submental, right underneath the chin. So no tenderness, no hard nodules noted in that area. The patient would be suspected of having an infection of some sort. Within the lymph nodes would be enlarged and they would be palpable or tender. The axillary nodes, you want to go ahead and palpate for those as well. I'm going to do the temporal. I'm going to palpate the temporal artery here. Feel for the pulse. Okay, 2+, regular. I'm also going to check for bruit. My diaphragm and my stethoscope. Okay, bruit there. Next, I'm going to start with my eye exam. I'm going to be viewing I already visualized the external, also the sclera. I did not mention on the sclera that it is nice and white, no yellowing, no jaundice, which can be indicative of maybe something's wrong with the liver or the the gallbladder. Let me go ahead and grab the equipment I need for this next exam, which is my otoscope. Okay, the first assessment I'm going to be doing on the eyes is going to be the direct and consensual pupil response on the patient. Go ahead and look straight at me. Okay, that's direct. The pupils are equally round and reactive to light. And then when I shine my light onto the left eye, if I look at the right one, it constricts. Vice versa, when I shine the light onto the red one, the left one constricts. That's direct and consensual eye exam. Now I'm going to be doing the corneal light reflex. I'm going to have a patient look right at the nose area. Come on in. I see that the pupils are, they do dilate and they are to the nearest, looking for like an astigmatus in this one assessment. The next assessment I'm going to be doing is the confrontation assessment of the visual fields. Tell me whenever you can see my fingers. There. There. Okay, very good. The next assessment I'm going to be doing is checking for the extraocular movements of the eye. And this is also a cranial nerve, but when I get down to my neuro, I'll go ahead and redo it. Okay, go ahead and follow my finger, the cardinal gaze test. Midline, back, down, across, midline, up, center, down. Very good. I didn't note no lagging in the eye, no nystagmus of the eye during this assessment. I'm going to grab a sheet of paper and do the cover test. At this point, when I cover the eye, the unaffected eye, I don't want to see any movement. Okay, look straight at me. Very good. Look straight at me. Okay, very good. Eyes stayed midline, no movement, no lagging of the eye. Okay, the next test I'm going to be using is with my fundoscope, and I'm going to be looking in the internal parts of the eye, which is the iris, the optic disc, the blood vessels, and the red reflex. I'm going to dim the lights for this. Can you see me there? Coming in at an angle, I'm going to be assessing the left eye first using my left eye. Okay, red reflex is present. Coming in, looking in to, I view the optic disc, the blood vessels, no hemorrhaging noted. The other eye, I'm going to be assessing your right eye using my right eye. Angle, okay. Red reflex present. Blood vessels, no hemorrhaging, optic disc noted. Okay, that was the fundoscope exam of the internal eye structures. In this part, if the patient had maybe diabetes, we possibly could see hemorrhaging, cataracts, glaucoma, and everything was, my patient passed. Everything was good for my patient. The visual acuity test, I'm going to go ahead and do for my visual acuity test, I'm going to do towards the end of my assessment. When I'm doing my neuro exam, I'll have my patient do the Selin chart. down to my eyes. Now I'm going to be checking my patient's ears. First, I'm going to be palpating the pinna or the ocular for any tenderness, any inflammation, any nodules. Note for any drainage around the ears. I'm going to perform the, I'm going to view the internal ear, looking for the tympanic membrane. Disregard, let me grab a tissue. I'm going to be doing the internal, looking for the tympanic membrane, viewing for any bulging, redness, cobblestone appearance for the patients that may have sinus issues. You always want to pick the pinna up and back on your adults. Okay, I see the tympanic membrane, and it is a grayish white color, which is normal. No redness, no bulging. Pin it back. Same on this ear. The tympanic membrane is nice and a yellowish, not yellowish, a white gray color, which is a good indicator of a healthy ear. No inflammation, no redness, no bulging, cobblestone appearance. And I'm gonna now do the whisper test on my patient. First, I'm gonna go ahead and include one ear. I'm gonna say a 2-syllable letter, and the patient is going to repeat it. It's whisper test.
Baseball. Rainbow.
Okay, so patient passed the whisper test. The next test I'm going to be doing is the Weber and the Rainier test. And this is checking for air conduction and bone conduction and hearing loss in the patient. I'm going to be using my tuning fork. I'm going to place this instrument on your forehead here, and you're going to tell me which ear you hear the vibration louder.
It's equal and the same.
Okay, and that was the Weber test. Now I'm checking for the bone conduction. Now I'm going to be doing the Rene test. First, I'm going to place it on the mastoid bone, and then I'll place it, the air, beside the ear. When you no longer hear.
There. There.
Good. Very good. I'm going to do now the other ear. Same thing. Make sure I don't touch the. You no longer hear it.
There.
I should have done on the exam table instead of in the chair. Sorry for my awkward positions.
There.
Okay. So the patient passed the Rene test. She had a 2-to-1 ratio on her. She heard it double, the ringing double in the air conduction. This is when we would be checking for conductive hearing loss on the patient. Okay, that was my ears. I'm going to go down to the nose, which I've already done the assessment of the nose that it is midline. I'm going to go ahead and check inside the nares for any spectrum deviation. I'm going to go ahead and if you can extend your neck for Bring your head back a little. And then kind of push up on your nose here. Looking into the nares, I know clear drainage, no redness or inflammation or polyps noted in the nose, no spectrum deviation, equally and bilaterally. Very good. Now that I have you here, can I have you open up your mouth? Let me grab my tongue blade. Go ahead and open up your mouth. Say ah. Okay, I'm in here, I'm looking at the uvula, that it is midline and pink. Tonsils are not enlarged. The hard palate is intact, no redness, no swelling. Looking around for dental caries inside the mouth. The patient's gums are nice and pink. I'm gonna go ahead and have you stick out your tongue, and I'm gonna go and lift it. Okay, it's even. Okay, at this moment, I can also check the vagus nerve, in which is the gag reflex, and that is cranial nerve number 9. Okay, very good. I'm also going to be checking cranial nerve number 10, which is the glossofacial, and the patient, excuse me, go ahead and swallow. Good. That's also a cranial nerve. Go ahead and swallow for me. Okay, perfect. The patient's able to swallow. That's cranial nerve number 10, and cranial nerve number 12 are the movements of the tongue. If the patient was suspected of having a stroke, you would see any weakness or lagging of one side of the tongue. Go ahead and stick it out. Stick your tongue out for me. Tongue movement. Push the tongue down. Very good. Okay, so I view the structures. Now I'm going down to the neck, being that it is symmetrical, which said the trachea was midline. I palpated for the, let me palpate for the thyroid. View no goiter on the patient. Okay, go ahead and swallow. Okay, the thyroid is not enlarged. The next assessment I'm going to be going on to is going to start with the chest, the lungs, okay, and then I'll go into cardiac. So at this moment, I'm going to have my patient, if it's okay, if you go ahead and remove your shirt for me and get on the exam table. Don't worry, it's only my professors in this video. Okay, starting off with the chest, the respiratory, I see that the chest rises and falls evenly. I see that the patient is not in any respiratory distress, no accessory muscles being used at this moment. The skin color is normal for ethnicity. I view no cyanosis. This is also like a cardiac exam. I know no cyanosis of the of the lips. So I've done my inspection of my anterior chest. I'm gonna go ahead and come over here for the posterior chest, as long as you can still see me on the video. Everything is symmetrical here, an even rise and fall of the chest. Okay, next I'm going to be doing my palpation and percussion. The first thing I'm going to be checking for is for the tactile fremitus. I'm gonna have the patient repeat after me, 99. I wanna make sure I hear that nice vibration throughout the lung fields. If I have any absence of the vibration, it could be subjective of a possible pleural effusion, or for our patients that have COPD or emphysema, this assessment probably would not, the patient wouldn't pass. Okay, repeat after me, 99.
99, 99, 99, 99, 99.
I'm gonna go to the anterior chest and repeat again.
99, 99,
Raise your arms for me a little.
99.
Very good. So I heard the vibration on all the upper lobes and lower lobes, anterior and posterior. The next thing I'm going to be checking for is the thoracic expansion of the chest, that I have a nice even rise. Okay, what I'm going to go ahead and do, and if you want to go ahead and come behind so you can kind of see what I'm doing, go ahead and take a deep breath. Okay, that was a nice even fall move for the thoracic expansion. Okay, that was and one more thing that I forgot on my palpation is to check for any crepitus. If we know that there's any air trapped, you would hear some like crackling sounds up around this area of the upper chest. Okay, which our patient here does not have that. And next I'm going to be doing percussion for the diaphragmatic excursion. Let me grab a pen for this one. For this assessment. Okay, what I'm going to have you do is take a deep breath and hold it. And start now. Okay, go ahead and take a couple of breaths and relax. We give the patient a couple of minutes too, and what we're doing is we're measuring the lung field. Okay, now I'm gonna go ahead and have you take a deep breath, blow it out, and hold it there on the exhale. Okay, starting from where I left off. You hear where the sound changes. Go ahead and release. And that is the measurement, more or less, of my lung field. And that was a diaphragmatic excursion. For percussion, next I'm going to be auscultating the lung fields, starting with the anterior chest. Breath. Deep breath. Deep breath. Deep breath. More to this side. Deep breath. And one more time. Deep breath. I heard vestibular breath sounds on the anterior chest. I'm coming to the posterior chest. Take a deep breath. Inhale and exhale again. Anterior and posterior lung fields were clear. I did not hear any wheezing, crackling, or diminished lung sounds on my patient throughout all her lung fields. So that was good. The next assessment we are going to be starting with is the cardiac assessment. Okay, so I'm gonna go ahead and let me just pin up my hair real quick because it's getting sorry. Just keep the video running. Okay. Okay, the next assessment is going to be the cardiac assessment. I'm gonna go ahead and start off with the inspection. So I'm inspecting the patient, looking around for her skin color, making sure that she has a nice pink color, that that she's getting good perfusion throughout her body. The color is normal for her ethnicity. I see no, I'm gonna go ahead and lay you flat for this exam, sorry. Okay, I visualize no pulsations, especially around the carotid artery. If you can go ahead and look at me. And this is also where you can view for the jugular vein distension, which I will assess that on the right side. So I'm starting off with inspection of my cardiac. I note no cyanosis around the lips. I know that her color is normal for ethnicity. I'm coming down and checking for capillary refills, making sure that, you know, they refill within less than 2 seconds. Patient has good perfusion. Okay, I'm gonna go ahead and palpate the carotid artery. The carotid artery is palpable. It is a 2+. I'm gonna listen for any bruise. Using the bell of my stethoscope first. Okay, no bruise heard. Using the bell of my stethoscope. I mean the diaphragm of my stethoscope. Okay, very good. Having the patient continue on looking onto the left-hand side, I'm visualizing for any jugular venous distension, which it's kind of hard to note in a patient that doesn't have any cardiac issues. For our patients that have more like congested heart failure, you'll see the bounding pulse, it'll be visible. Sometimes on our healthier individuals, right here at the sternal notch, you'll be able to see the pulsating of the JVD. Okay. Continuing on, I'm going to be palpating my pulses throughout the body. Starting off with, can you see me? Can you see me? You don't have to get right, but if you want to stand on that side, so you don't have to be right on top of it. Starting off with the aortic valve. It's on the second intercostal space to the right side of the chest. Feeling for that. Then I'm going to move on to the second intercostal space on the left side, checking for the pulmonic going down to the first intercostal space. I'm going to be looking for the tricuspid, trying to see if I see any bounding pulses going down to the apex of the heart, the mitral valve. You would check it around this area. Next, I'm going to move on to my pulses, starting off with my brachial pulse first. It is a 2+. Great. Checking out on my radial pulse. Perfect. Going down to the femoral. Sorry, sister, this may be uncomfortable. Femoral pulse. This is kind of hard to get. Going down to the popliteal pulse, right behind the patellar. The posterior tibial pulse, the dorsal pedal pulse. Also, when I'm checking these pulses and feeling for them, I'm also continuing on to assess for the skin color in the lower extremities and the hair distribution throughout, which is good. Any absence of hair, then we would worry of possibly decreased circulation. Also, the hair on the toes is something that you want to check that there is the color cap refill less than 2. Bounding dorsal pedal pulse, great. Hair evenly distributed. I'm gonna go back and repeat I already did the dorsal pedal. I'm gonna do the posterior tibial pulse, the popliteal pulse. The femoral. The brachial. Radial. Okay, very good. I'm gonna do 2 exams here that they check for deep vein thrombosis when you thinking that a patient may have a possible DVT to the lower extremity. Patient will be complaining of calf pain, possibly any redness or warmth also noted. For right now, I'm gonna have the patient fully extend the leg and then go ahead and flex it for me. No. Flex your foot. At this point here in their calf area, they will be experiencing pain, and that would be a positive Holmes sign test. Okay, if you can go ahead and sit up for me for just a moment so we can do the ulnar. The ulnar test, and this is just checking for perfusion to the hands in case you wanted to ever draw for ABGs here in the arterial. This is a good way to check for it. So I'm gonna go ahead and press down here. You're gonna squeeze your fist 5 times. 1, 2, 3, 4, 5. Okay, patient's color returns to normal within less than 5 seconds. Again, 1, 2, 3, 4, 5. Undo, and the color returns back to normal within less than 5 seconds. Now that we're here and I have my patient sitting up, I did forget to mention on the assess inspection part that the patient does have some striae, but a light whitish color bilaterally on each side. Also on the head and neck, when I was doing my pulses, I remembered that I forgot to do the maxillary and frontal sinuses of the patient. That is always something you want to do to note any tenderness or inflammation in these areas. Okay, that was my cardiac assessment, and now I'm going to be doing my abdominal assessment. I'm going to have the patient lay flat again. Sorry. Okay, with the abdominal assessment, we always want to start off with inspection. Inspecting the abdomen area, it is round, and that's where I could have said about the striae noted on both sides. You're viewing the umbilicus, that it is midline, no discoloration or bruising noted around that area, no abnormal pulsations as well. And I'm going to be checking for the aortic aneurysm. That was part of the cardiac, but since I'm doing my abdomen right after, I was going to work it into there. So I start off with inspection of the generalized abdomen area. It is round. I'm next going to start off with auscultation. When it comes to the abdominal assessment, we always want to do auscultation after inspection so we don't disturb any of the bowels or if there is an obstruction or something going on in the abdomen. Starting on the right lower quadrant. Right upper quadrant, left upper quadrant, right left lower quadrant. Patient does have normal tinkling sounds, which is good. a good indicator for productive bowels. If you were to have abscess or periac ileus, it would be more worrisome of a possible obstruction, constipation of the patient. Also, I'm going to be listening now for the aortic aneurysm for any bruits. First, I'm going to go ahead and palpate for any pulsating. First, I'm going to do it with the diaphragm and my stethoscope. And with the bell of my stethoscope. Okay, no bruits heard. The next, I'm going to be listening for the liver and the spleen for any friction rubs if I were suspected of any trauma or injury to those areas. First with the liver. And the spleen. Okay, no friction, no rubs. Next, I'm going to do percussion. I'm going to be percussing the abdomen around the organs. I will hear dullness, and around the fluid and the air, I'll hear tympany. Okay, I'm sorry, keep on moving around. I'm going to come around onto the right side where the liver is. I'm going to listen to percuss, starting off the right lower. You hear like a tympany, and then you hear a change. You can hear the dullness. Patient's liver is probably about a good 7 centimeters in length. I'm now going to be assessing the spleen. I don't know if it's better if you stand like there so you're not. Very well, I went ahead and I percussed the liver and the spleen and around the abdominal area. Next, I'm going to be doing a light palpation, starting off on the right lower quadrant. At this moment, when you begin with the palpation, you always want to visualize the patient's facial expressions. That would indicate if they have any grimacing, that they're experiencing pain, and in which quadrant. You always want to start off with light. It's just to get the patient used to your touch. And if they're ticklish or if fingers are cold, it just kind of warms them up. With one palm, the tips of my finger pads, just go ahead and go in a little circular motion, feeling for any nodules, any masses. Next, I'm going to be doing like a deep palpation. Again, feeling for all those masses, lumps, and also viewing the facial grimacing of the patient. The next thing I'm going to be checking if you suspected that your patient may have cholecystitis or inflammation of the gallbladder. These are one of the tests, the hook tests that you can perform to see if the patient will experiencing pain during this assessment. I'm going to have you take a deep breath. And you would kind of hook underneath this rib cage here where the liver is. And if the patient was grimacing or had pain, that would be a positive indicative of the cholecystitis. The next exam I'm going to be doing is the iliposis exam, and this is checking for appendicitis. All these next exams are going to be for the appendicitis. Okay, for the ileosis, I'm going to have the patient lift the leg. Straight up. Okay, and at this moment they would experience pain. The next test I'm going to be doing is the abductor. And you're going to have the patient flex the leg. Can you bring your knee to your chest? And at this moment, the patient will experience pain. Okay. And the next test is checking for rebound tenderness. And I'm going to you view the umbilicus, you view the crevice of the hip, and I'm going to push down and release. Positive if the patient has the rebound tenderness. The last test is checking for ascites or fluid in the abdomen. If my patient came in with cirrhosis and extended abdomen, possible fluid in there, I'm gonna need your help with this assessment. Go ahead and give me one of your hands. Curve it like that, put a little pressure down. And I'm gonna put one palm on the opposite side, and then I'm gonna strike this side of the abdomen. And if it was a positive, you would see a fluid wave of hit on the other hand. And that is to check for fluid in the abdomen, and that was a fluid wave test. And this is the end of my abdominal. I'm going to be starting on my musculoskeletal exam next. Okay, have you sit up for me right now? Stand up. Yeah, go and stand up. You all right? Okay. First, we are going to be assessing the neck. So if I can have you flex your neck down, great. And then go ahead and extend your neck back. Okay, and then we're gonna laterally bend your neck from right to left and then rotate it around. Okay, very good. Next, I'm going to move on to the shoulders. I'm going to put resistance here. I'm going to push down and see if you can. I'm going to push down and then you're going to, with resistance, ready? Okay, you see the shrugging of the shoulders is even. There's not one side stronger than the other side. This is actually cranial nerve number 2. And the next thing we're going to be moving on is to the shoulders. The first thing I'm going to have you do is do abduction away from your body and then adduction. Can you repeat it with your other arm? Abduction and adduction. Okay, very good. The next is going to be the scratch test. This is also what you check for a rotator cuff. But it's checking the internal and external rotation. If you can go ahead and lean over and like if you're gonna scratch your back, very good. And then hyperextend and scratch the other back. So patient has no pain, no deformities noted, able to perform that test without any pain. The next exam I'm going to be doing for the shoulders is all for rotator cuff maneuvers to see for any tears. The first one is going to be the near test. And on the near test, what I'm going to do is I'm going to go ahead and put my hand behind her scapula and then internally rotate her arm, lift it up. At this moment, if it was positive, the patient would be experiencing pain, and that is the near test. Another one that we check for rotator cuff tear is when we do the drop arm. I'm going to go ahead and laterally lift her arm up high, and then at this moment, if it was positive, her arm would just drop. That would be a positive, just from up and a drop. But this patient was able to bring down her extremity or adduct it without any issues. The next test to check for rotator cuff is the Hodgkin's test. And with the Hodgkin's test, you're going to flex the arm, hold it up for me, like flex your arm, and it's like you're gonna give a high five from the back in a 90-degree angle. And at this moment, in this maneuver here, you would experience, the patient would be experiencing pain. Okay, and that was the Hodgkin's test. The next assessment I'm going to be doing are of the elbows. So if you can flex your elbows and then extend them for me, very good. And then if you can do subnation and pronation. Subnation and pronation, no difficulties noted there. On the elbows, you also just want to feel for any deformities that the patient may have on the elbow. Next, we're going to move down to the wrists. Also, can you flex and extend your wrists? No problems or difficulties there. Can you also do the pronation and subnation of your hands? Very good. Okay, no difficulties there. You can also do the adduction, the abduction. Okay, your fingers as well, adduction and abduction. Very good. And lifting, flexing, and okay, very good, sister. The next thing I'm going to be checking for is for the carpal tunnel, and in this maneuver, we're going to have the patient flex her hand downward, and I would just tap here at this nerve, and if it was positive, the patient would be experiencing pain. The next one is called the Fallon test, and it's like if you're going to pray, but upside down. Apply a little pressure right here in this area, and the patient will be experiencing pain, and that is the Fallon's test for carpal tunnel. Okay, moving on, we've done the shoulders, the elbows, the wrists, the hands. I'm gonna go ahead and move on to the spine, which I'm gonna visualize the patient walk. Just walk in a straight line and walk back. I'm noting that there's no lagging or dropping. Patient doesn't have any shortening of one leg or the other, no difficulty with weakness on one side of the body. Now we're going to go ahead, if you can flex forward for me and stay in that position. I'm also going to be viewing the spine for any curvatures, and this is one of the exams they do for the scoliosis. Sorry, I was getting tongue-tied with that one. For any abnormal curvature of the spine. Okay, go ahead and stand up for me, sister, which this one is normal. Go ahead and go ahead and extension of the back. Great. Okay, now you can do lateral bends to your right and to your left. Good. Okay, then you just do a little twist. Okay, very good. The next, that was the hip. So now I'm going to have the patient lie down, back on top of the table. And I'm going to continue on assessing the hips. I forgot to have her extend her legs, but we'll do that when we stand back up. We'll extend the legs. I'm going to see if you can flex your knees to your chest. Okay. Flexion, very good. Back down. Now we're going to do internal rotation and external rotation of the hip. Starting with internal rotation, go ahead and flex. That's internal, and then external rotation. Okay, I'll do the other extremity as well. Flex, lateral. Or you can go ahead and bend it for me, and then just. Now that I have the patient here in this, position, this is going to be the Thomas test. If we suspect any hip displacement or dislocation, when you have the patient have this foot flat on the table, you will view a spacing in between the other leg. And we can do the other leg to test it too. Very good. I'll put it back out. You view no shortening of the leg. If you suspected a hip dislocation, that would be another indicator of shortening of the leg. Now I need you to do abduction and adduction. First would be abduction, opening up, and then adduction. Okay. Can you do that separately, each leg? Okay, very good. We did the abduction. Okay, next we're going to be moving on to the knee. Okay, first I'm going to have the patient flex for me. Great, patient's able to flex the knee. And I'm going to be performing a couple of maneuvers to check for any knee injuries, mainly sports injuries. For meniscal tears or ACL re-tears of the lateral or the medial aspects of the ligament. The first one I'm going to be performing for you is going to be the drawer test. In the drawer test, I'm just going to have the patient with the knee flexed, flat on the ground. I'm going to put my fingers behind the popliteal beneath the tibia and the fibula and just pull here. If it were positive, they would feel like a drawer. You want to put a light tug, not too much force, and that's the anterior drawer test. And then the posterior drawer test is the same maneuver, except you would posterior. You're gonna go ahead and push back. And that was the drawer test. The next test I'm going to be performing is the McMurray's test. And the McMurray's test, I'm gonna have, if you are suspecting a ACL tear, this is where you have the patient bend, and then I'm going to first do this several times, kind of laterally come down, and then flex the knee again, and then laterally come down. You would feel some, it wouldn't be as firm as it is. There would be some like some loose elasticity of the foot. The next one I'm going to be doing is the vagus stress test, and that one is also checking for, first I'm going to be checking for the lateral aspect of the knee for any meniscal tear. I would be going to place my hand right above the popliteal and just kind of gently jerk the leg, and if there is any kind of like that kind of give, and you may want to kind of bend the knee a little to make it a little easier. Okay, there's no giving of the knee, and that is the vagus stress test. Another thing we check for, like bursitis or any fluid in the knee, the first one is called the balloon test, and that's when we kind of like milk the thigh to the knee, and then also up on the lower leg, and you would get like a balloon of fluid here, and that is a balloon test. Also, the ballot sign is whenever you just tap the knee and you can actually feel the fluid disperse through. Okay, and that was for fluid in the knee. We did the valgus stress test, checking for ACL tears or medial or lateral tears. We did the drawer test, looking for also ligament tears of the knee. Next, I'm going to be going down to the ankles of the patient. First, I'm going to have you flex both feet, flex them for me, and then extend them. Okay, and then do abduction and then adduction. Very good. And then with your toes, can you also do flexion and extension, and then abduction and adduction? Okay, very good. Now I'm gonna go ahead and complete the musculoskeletal by having the patient do the knee extension and flexion and extension of the knee, and also if the patient can do the yes, that's all we have left. And then for the hips, the extension. Okay, starting off with the knee facing that direction, I need you to flex your knee up. We'll do your right, now your left. See if there's no abnormality, patient has good balance, no deformities, go ahead and flex. Okay, flex the other one. Okay, now checking for hips, because I didn't get to do the extension. I want patient just to flex the leg back, straight back, extend it, extend the other one, not flex, but extend. Very good. Also, there are no deformities or abnormalities of the musculoskeletal system. I did the McBurney's when I did the abdomen. Yes, I did. Okay, now I'm gonna have my patient put her shirt back on, and we're gonna continue on with our neuro assessment. For my neuro assessment, I'm going to need for my sense of smell, my touch. Okay.
First and foremost, when we're be performing a neuro assessment, is because we're suspecting a stroke, a TIA, patient coming in and complaining of either abnormal or headaches, abnormal gait, weakness, facial drooping. This is when we would be performing the neuro exam. Okay. First thing I'm going to be doing for my patient is asking her some general questions just to check her neuro status. Can you tell me your name and date of birth?
Andrea Breda, 090502.
Okay, and where are we today?
Buffers, Texas, the dialysis center.
Okay, and that's like orientation. Next thing I'm going to be checking is like abstract thinking. Can you tell me what an orange and an apple have alike?
They're both fruit.
Very good response. That's a good. The next thing I'm going to be doing is checking for like attention. If you can count in increments of 10, 100, back to 1. Does that make sense?
Mm-hmm.
Okay.
100, 90, 80, 70, 60, 50, 40, 30, 20, 10, 0.
Okay, very good. That was like the attention. Next is going to be comprehensive. I'm actually supposed to write on a piece of paper, and the patient's supposed to be able to read it and follow the direction. But I did not do that, so I'm gonna tell you, can you tilt your head for me?
Back.
Whichever way, just tilt it. Okay, and that is comprehensive. The patient's able to do that maneuver. The next one is the knowledge. Can you tell me the President of the United States?
Donald Trump.
Okay, very good. The next one is going to be judgment. If you were to find an envelope on the floor and it was addressed to somebody else, what would you do?
Return it to the address.
Great. One of the other things is memory. I'm going to repeat 3 words and you repeat them back to me. Burger, tulip, and rose.
Burger, tulip, and rose.
And also during this assessment, I'm listening for the articulation and the vocabulary of the patient. I view no stuttering. I view no confusion. Speech is cleared. These are all whenever you would check for the speech, the orientation of the patient. The next assessment I'm going to be doing is the cranial nerves. The first one I'm going to start off with is the olfactory, and that's the sense of smell. What I'm going to have you do is close your eyes for me. Can you tell me what this is? Keeping your eyes closed.
Coffee.
Very good. Can you tell me what this is?
Vinegar.
Okay, last one.
Vanilla.
Yes, it is vanilla. Okay, the next one I'm going to be doing is the optic test. So I'm going to be checking for pupil responses. This is cranial nerve. No, I'm getting myself. Hold on. The next cranial nerve I'm doing is the optic. It is the optic of the eyes, sorry. Okay, go ahead and look at me. I'm looking for the pupil response. Pupils are equal and reactive to light. Okay. I'm gonna check for accommodation. Follow my finger. Great, okay. Next, we're gonna be using the Selin chart here. Checking for visual acuity of the patient. I'm going to have you stand about 10 feet, which is probably about to this line right here, using my reflex hammer. Can you close your right eye for me? Cover your right eye.
E, F, P, T, O, Z, L, P, E, D, P, E, C, F, D. E, D, F, C, E, P, F.
And that's okay. One question that was of the left eye. One of the questions I was supposed to ask the patient was, do they wear glasses or contacts? Do you have glasses or contacts that you use?
Contacts.
Okay, very good. So on the left eye, it was a 20 to 25. Now I'm going to have you cover your left eye and we're going to examine the right eye.
E, F, P, T, O, Z, L, P, E, D, P, E, C, F, D, E, D, F, C, Z, P, FELOPZD DEFPOTEC.
20/20 vision on the right eye. And that was checking for the visual acuity, and that is cranial nerve number 2. Cranial nerve number 3, 4, and 5 is checking the ocular motor, the trochlear, and the ocular motor. It's all 3 are the eyes. So I'm going to be using my fundoscope to looking in the external, looking for the optic disc of the eye, and I'm going to be doing the cardinal gaze, looking for the ocular movement. Okay, go ahead and have a seat, sister. Which I performed this in the eye exam, but I didn't want to forget, so I'm going to go ahead and just redo it again. So I'm coming around to the right eye, my right eye. I'm viewing in the internal structures of the eye. Very good. Optic disc noted. Blood vessels. Okay. Next, I'm going to be doing the follow my finger. This is checking for extraocular movement of the eye. Follow my finger. Very good. And that was those were 2, 3, and 6. Because 5 is facial sensation. And with that one, I'm going to go ahead and grab a Q-tip and a gauze. And I want you to have you close your eyes, and you're going to tell me if you feel this dull, sharp, or soft. Start off. Dull, 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 dull. Okay, next.
Sharp, 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 sharp.
Okay, next.
Soft, 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 soft.
Okay, the next cranial nerve is going to be 7, and that's going to be facial expression. I'm going to have the patient smile really big. Close your eyes really tight. Go ahead and raise your eyebrows. Okay, and you note that everything is equal and bilateral. There is no facial drooping or facial weakness that you would note on this assessment. The next cranial nerves is 8, and that is the hearing using the Weber and the Rene test, which we did when I did my ears. So I don't want to have to repeat the whole thing, but this is checking for air conduction and bone conduction and hearing loss on the patient. This is when we did the Weber, and then this was the Rene. Okay, that was 8. Number 9 is the number 9 is the vagus, which we checked already, the gag reflex, which I did at the beginning of the assessment. 10 is the glossofacial, which I had the patient swallow, and we had her speak. She had no problems with her speech or with her gag reflex. Those would be indicative of some maybe post-stroke problems that would have been done. And we did cranial nerve number 12, the hypoglossal, when I had the tongue movement. So that concludes our cranial nerve assessment. The next thing I'm going to be doing is checking for the reflexes of the tendons. I'm going to go ahead and use my reflex hammer for this. The first one I'm going to be doing is checking for the tricep. So I'm just going to go ahead and strike this area. Very good. Come around to the other side. Okay. Then I'm going to be doing the biceps here. And then we're going to be doing the brachioradial. Very good. Very good. Next, I'm gonna be coming in and doing the popliteal here. I may wanna have you get on this exam table just so your legs stable a little more. Okay, the patellar here. You just kind of want to feel for that little space and then just, okay. Now the acelles, if you can get in a prone position, which is on your belly, so I can check for this reflex. Acelles is right behind the ankle here, just kind of lightly. There we go. Okay. Next, you can go ahead and sit back up. The next exams I'm going to be checking are like the motor skills, which I already saw the patient ambulate. That's one of them, is the gait. I'm going to have her do a rapid hand movement. If you can just flip your hands forward and back, supine pronation. Okay, very good. Follow a simple direction of finger to nose, visualizing that there's no pauses or no drooping of one side. Next one is going to be the heel to chin. What I'm going to have you do is just run your heel down your shin. There you go. And then opposite. Okay, patient's able to do that with any abnormalities. Next is going to be the sensation. The first one I'm going to be doing is the graphphasia. I'm going to draw something on the patient's hand, and they're going to tell me what it is. Okay. Tell me what I'm drawing on you.
Move forward.
Yes. Okay. Again.
Number 8.
Very good. Okay. The next one is going to be the sericil sensation. Is the patient's going to have their eyes closed and they're going to try to identify what type of object I place in their palm. Okay. First one. Go ahead and close your eyes. Close your eyes. Can you tell me what that is if you feel for it? With one hand, with this one hand, sorry.
A coin.
Very good. I'm going to put another object, keep your eyes closed.
A key.
Okay, and then another object, keep your eyes closed.
Paper cut.
Okay, I'm going to come on to the other hand and repeat. Keep your eyes closed.
Coin. Key. Paper cut.
Okay. Next, I'm going to be checking for the sensation on the upper and lower extremities on the patient. Okay. First, go ahead and close your eyes and tell me if you feel this dull, sharp, or soft.
Sharp. 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 Sharp.
Next.
Dull. 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 Soft. 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 Soft.
Okay, and this completes my head to toe assessment. Hopefully I did okay.